Good afternoon, everyone, and welcome to the webinar. Professor Dr. Kenny Rodriguez-Wallberg will start with the introduction.
Hello, I am delighted to present this webinar, which is a collaboration between the SIG Safety and in Art and the Fertility Preservation SIG. We will start with the introduction by Professor Richard Anderson and the presentation of the guideline, and then we will have the possibility to write questions and get answers after the presentation. And we will have the concluding remarks. In the next slide, you will see that during the presentation, you can enter your questions at any time, and you can do it in the chat box in the right of your screen. You can just type your questions. If you wish a certificate of attendance, it's going to be delivered by the recording link, and it will be a good thing to give us your feedback after completing the survey for the webinar. Thank you.
So if we can move on to sharing my screen. Just get that organized. Great. Okay, I hope you can all see that clearly. So thanks very much, Kenny, and thanks to ESHRE for putting on this webinar. My name is Richard Anderson. I'm at the University of Edinburgh, and it was my privilege to be chair of this guideline development group over the last couple of years. And what I want to do in the next 20 minutes is to give you an overview of this document and our recommendations. We developed overall a total of 78 recommendations from this, so I'm not going to go through every one of those. And of course, they're all available online. But I want to highlight how we did this and what some of the key things that we concluded in this work. Of course, ESHRE has a very robust methodology for these guidelines, and they're now been very well established. And we were very privileged to have Natalie Vermeulen as our key guide and mentor in this to make sure that it was all done to the highest standards. If you want to look up the details, they're available in this manual. But essentially, it involves designing the key questions that we wanted to address. Critically, an evidence search and an evidence synthesis, because these are very much evidence-based guidelines, drafting the recommendations on the basis of those evidence. And then when that is all put together, it all goes out for stakeholder review, which is very valuable. And actually, we had a lot of stakeholder comments, which I'm sure improved on the document in the end. And actually, that review process, that review document is viewable by all on the ESHRE website. And then that then gets approved by EXCO, and a summary of the guideline itself is obviously on the web, and a summary publication is in process with human reproduction at the moment. We also have a patient information leaflet that we derive from this as well. And this will then be revised in some 5 years' time, as I'm sure a mountain more evidence will have been arrived at by then. So the weight of the recommendations come as either strong or weak, and may be applied to patients, clinicians, policymakers, depending on the level of evidence underpinning them. We also, of course, have research-only recommendations, and where there isn't sufficient evidence, but we think it's an important practice point, we highlight that, and as its name suggests, label it as a good practice point at GPP, and you'll see that throughout. And clearly, those are areas where there's also more evidence and more research needed. One of the key things at the beginning of this process was to really discuss and agree on which patient groups we wanted to include in this guideline. And we decided on these 4 key groups. So they are post-pubertal women who have a condition where the condition or its treatment will compromise their future fertility. A second group of women may have a condition that may itself compromise their fertility, such as Turner syndrome would perhaps be the classic example of that. We wanted to include transgender men who may wish to store eggs or perhaps embryos for their future fertility. And we also included women who were requesting oocyte cryopreservation for age-related fertility loss. And of course, this is therefore not a comprehensive overview of every group for whom fertility preservation might be needed. And we specifically did not include prepubertal girls, and we didn't include males, either prepubertal or adult. So an overview of the guideline then perhaps falls along this universal pathway. And I'm going to go through this in stages because this is how we sort of put it together and design the final documents. So we start off with an overview of how a service might be organized and the provision of information and decision making for the patients, going on to pre-fertility preservation patient assessments, then the actual interventions themselves. In the yellow, we have what might happen to the patients, and then, very importantly, we include a substantial section on after treatment care, because of course the whole idea of this whole process is to ensure a healthy, successful pregnancy and live birth at the end of it, rather than just the cryopreservation aspects of things. So we wanted to include the whole patient journey from referral right through to potentially having a live, successful pregnancy at the end. So one aspect of this is the need to consider the organisation of the care. And the key aspect of that is the need for a team approach. This is a multidisciplinary process. There will be a whole range of different diagnoses and therefore different clinical care groups looking after the patients and referring them into the fertility preservation system. And there needs to be excellent links between these groups. That will, we felt, preferentially involve multidisciplinary team meetings, but we also highlighted the absolute key role of an individual, termed a coordinator here, who will support the patients, provide linkage between these groups, and provide links to support and counselling, which also should be available to these. And of course, there is a need for accurate documentation, which may need to be covering the storage for potentially many years. The first thing, of course, is providing information to the patients and helping them make a decision as to whether or not they wish to go down this pathway, and if they do, how they wish to do that. So we had a number of recommendations on this, some of which were strong, particularly fairly, as you might imagine, fairly self-evident, that patients should have information regarding the impact of their condition and the treatment on their future reproductive function. That information should be specific for the patient, and for younger patients should be age specific as well. How that can be provided has classically been in the form of information sheets, but there's now growing evidence that decision aids are actually a much better way of helping patients make these complicated decisions, and there are now decision aids available for patients in many of these groups that will help them do that. So that was a strong recommendation. We felt that a checklist might be useful, and we did feel very strongly and made a strong recommendation that psychological support and counselling are going to be very important for many of these patient groups, but it has to be admitted that the extent of benefit of that has not been robustly studied and is a key area for future research. What about assessment of the patient when as to their essentially medical fitness for this and the risks that they're associated with this? Well, obviously, this is going to require an individual assessment. Again, we highlighted the need for a multidisciplinary group approach to this. And we also felt that it was appropriate to specify that for women with actual overt premature ovarian insufficiency, unfortunately, fertility preservation is not going to be recommended. That ship has sailed, so to speak. When you assess patients for this, there is now good evidence and a strong recommendation that it's possible to assess the risk of individual toxicity relating to the condition, the treatment the patient is going to have, the patient themselves, and of course their underlying diagnosis. And that may help both the sort of surgical risks associated with some of these interventions, as well as the anesthetic risks, such as, for example, the risk of bleeding, risk of infection, and of course mediastinal masses, which are very important for example, in lymphomas when you're thinking about anesthetic risk. Another aspect of pre-treatment assessment is assessment of the ovarian reserve, and there is, of course, good evidence for that, the value of that in predicting the response to ovarian stimulation, which is going to be the most common intervention for this patient group. So that is robustly established. There is also some evidence that measurement of AMH, particularly for pre-treatment of ovarian function, is recommended for some prediction of recovery after treatment is completed, but there's very limited evidence, and it should not be used as an indicator of post-treatment fertility, and that is a misleading use of that particular biomarker. As we've said already, you can assess the risk of POI on the basis of patient age, treatment, dose, and potentially ovarian reserve biomarkers as well. But most of these data do derive from very much breast cancer, to some extent hematological cancers such as lymphomas in particular, and for many other conditions that's really much more limited, and it's a matter of extrapolating from one to the other if that seems appropriate. We are, of course, covering non-cancer diagnosis as well, and there's evidence in a number of these for these factors. Systemic lupus erythematosus was one where there's some evidence, but also endometriosis is perhaps a pressing problem with this. After much discussion and debate, we felt that it was important to highlight that the relevance of ovarian reserve testing in endometriosis really remains inconclusive, and that is unfortunately only a weak guideline, but I think an important one. What about the interventions themselves? What are we going to offer? Well, you'll have seen versions of diagrams like this, perhaps in previous publications, but I think this sets out the patient journey and the options available, and then what are the consequences for what you end up storing for subsequent use. And that's important to go through with the patients, what are the implications of what might happen to them and what they might be able to use further down the road. And so you can see that that may involve autotransplantation or replacement of oocytes or embryos. And indeed, we highlighted in some circumstances, of course, a surrogate will be required for that. And that's where the variety that makes up the European legislative situation becomes very important, because of course not all these options are available in every country, and we included some substantial tabulation in the guideline of what is the current legislative situation across the European countries, of course, though recognizing that is subject to rapid change. But it's an important recognition that not everything is always available. So how are we going to go about this? Well, for women wanting to store eggs or embryos, of course, the first step in treatment is ovarian stimulation. And during the course of development of this guideline, the ESHRE Guideline on ovarian stimulation for IVF and ICSI was published, and that included a section on this approach for fertility preservation, which we largely adopted with some adaptation. And we agreed with that group that the key ovarian stimulation protocol that's of relevance is the antagonist protocol because of its safety, its rapidity, and therefore very useful for these particular urgent situations. However, that does not exclude the use of a long protocol where the situation allows, and it also includes options for new developments, particularly in random start, which is now, of course, largely established, but potentially newer things like double ovarian stimulation were also options, but for many of those, the evidence remains fairly weak. For ovarian stimulation in breast cancer, or indeed in transgender men, we recognize the value of anti-estrogen treatments such as letrozole, aromatase inhibitors, in both those situations, but without really very robust evidence for their benefits, and therefore their good practice points. So oocyte cryopreservation, we concluded an established option for this, strong evidence for this, an option for women either single or in a partnership, or you could, of course, split the oocytes between fertilization and not. But what is important here is, and indeed this was a recurring theme throughout all these interventions, is the need for accurate center-specific information on expertise and local live birth rates, rather than just taking the best from the literature. What actually is the data for the patient and what she will get with her local center. We have a section on age-related fertility loss, and that again highlights this need really for specific and accurate information for women considering this based on these key issues: success rates, risks, benefits, costs, and of course, long-term consequences. And those are really important in that particular age group. You'll note that the terminology that we used here, this underwent some development. Historically, the term social egg freezing is also often being used, but we felt that was rather derogatory. And we also moved on from non-medical oocyte cryopreservation to this terminology of age-related fertility loss. Embryo cryopreservation, also an established option. The issue of loss of reproductive autonomy is of course very important with this, and again the need for accurate centre-specific information on this. We had a substantial section on ovarian tissue cryopreservation. That is an appropriate option for women undergoing specific treatments where they're at moderate to high risk of losing their fertility. And this may be because of time considerations, or it may be through patient preference. There is some evidence of an age-related effect on efficacy, as there is, of course, for embryo and oocyte, but the evidence surrounding this is relatively weak at present. There's been a lot of discussion as to what is the actual status of ovarian tissue cryopreservation, and we considered that we should conclude that it should be categorized as an innovative method, so not experimental anymore, but not yet fully established in postpubertal women, particularly with cancer and other recognized medical conditions. When you're talking about POI-associated genetic and chromosomal disorders, however, we felt that that was really an area where there's still a lot more research required, and its use in those patients we felt was a research-only application. Replacement of this tissue is, of course, the main consideration regarding that is the presence of residual neoplastic cells, a very key consideration in this, and we didn't recommend that this whole process should be performed when the ovary is involved in the malignancy. In vitro maturation of oocytes is now becoming more established. We felt at the moment it should be regarded as an innovative procedure, and there's now live births from that in a range of different diagnoses relating to fertility preservation. But it does require specific clinical and laboratory expertise, and therefore it's perhaps less widely available and really only used when oocyte cryopreservation is required, but the ovarian stimulation is associated with the risks or in some way not feasible. In vitro maturation after ex vivo extraction is also a possibility, but we felt that this was still an experimental procedure and therefore essentially something to be largely considered in a research capacity. One of the most difficult areas that we discussed at length was actually the value of gonadotropin-releasing hormone agonists as ovarian protection. And this is actually an area where there is perhaps some of the best evidence of an effect through large randomized controlled trials. And we felt that therefore there was strong evidence that it should be offered, particularly in premenopausal women with breast cancer. But the evidence in terms of outcome on ovarian reserve and future pregnancies is still quite limited, and therefore we had that caveat in that recommendation. We felt it was very important that because of those caveats, it should not be considered as an option for fertility preservation instead of other more established cryopreservation techniques, but as an adjunct would be its primary place. There's also a lot of debate as to whether the data from breast cancer can be extrapolated to other cancers, and we felt that GnRH agonists should not be offered routinely in other malignancies because of this uncertainty about benefit, but certainly something that could be discussed with patients as to whether they wish to go ahead with that form of treatment. Transposition of ovaries is always going to be another potential option for intervention as prevention. Again, the evidence here is largely very weak, and we felt there were situations such as women with a reduced ovarian reserve or where there were ovarian malignancies potential, that these were probably inappropriate situations for this intervention. One of the things I think that is really valuable about this guideline is the after-treatment care aspect of it. So we have a substantial section on assessment of patients before using stored material, particularly discussing fitness for pregnancy, as well as the likely success. And within that, of course, there is the need for counselling, both psychological and preconception, and for, of course, related to the specifics of what fertility treatment might be involved. And again, local guidelines for counselling will come into play here. So you can see we actually managed to have several really strong recommendations regarding this on the obstetric outcomes, and this is a very important area where there is now substantial evidence. So we recommended the need for counselling, for obstetric monitoring, and highlighted the serious risks involved where there's been radiotherapy involving the uterus. Importantly, we provide a strong recommendation that the literature now clearly support that pregnancy is safe after breast cancer, independent of estrogen receptor status. And that is something that patients need to be aware of and be supported in their decisions in that. However, there are also data that pregnancy after breast cancer may have an increased risk of preterm birth and low birth weight, and therefore the patients should be monitored and patients should be aware of these risks. Similarly, there is some evidence in the pregnancy in transgender men of an increased risk of depression and increased dysphoria, but an area where there is insufficient evidence, but certainly enough to make a recommendation of the need for increased awareness in that specific high-risk patient group. So what about the future? Where are we going to be going with this in the future? So we have a final section in the document about what might be available in decades to come, because some of these future things are long-term. So they can be roughly divided into those where the tissue, where they involve transplantation back into the patient, optimizing the use of ovarian tissue, making it safer by eliminating malignant cells, perhaps isolating follicles from that for replacement in the patient. Other techniques don't involve transplantation, so these are lab developments of oocytes from tissue, from isolated follicles, or even more futuristically, from pluripotent stem cells or mesenchymal stem cells. And of course, that has now been established in mouse, where you can actually do this, but of course, that's a long way from any clinical application. We also highlight that prevention is always going to be better than cure, and there's a whole range of potential protective agents that are being investigated. But again, these are largely at the preclinical stage, but some of them offer substantial hope for application in the not too distant future. So underpinning that then, as I pointed out throughout this talk, there are a number of research recommendations that we highlighted, and in fact they come from all sections of this guideline, right from patient information provision support through gonadotoxicity, the various cryopreservation techniques, protection, after treatment care, and the need for follow-up of children after this to ensure that these are healthy babies born and have a happy and long life thereafter. So in summary, we formulated 78 recommendations around these 4 different patient groups. We identified the key steps in the pathway that patients will have and identify recommendations for each of those steps on the patient journey. Of course, this is very much based on the best current available evidence, and that is going to be changing all the time. But at the moment, we'd like to think that this is a best practice based on the best evidence that we can identify at the moment. And of course, we have recommendations for research to stimulate other studies to improve this and improve our patients' care. So I've been fortunate enough to chair this group, and I'd like to just acknowledge the absolutely fantastic team that put so much work into this. I think any of you who've been involved in development of guidelines just know that this is a challenging and arduous process and needs huge commitment from a large number of people. So here are the wonderful team who were involved in this from all sorts of disciplines, of course, a lot of fertility specialists, but also from counselling, from laboratory studies, from embryology, from ethics and law, from oncology, of course, And we were very fortunate in having Caroline and Sandra as patient representatives. And of course, overseeing this whole bunch was Natalie, who kept it the show on the road and was absolutely fantastic in actually coming up with this really, I hope, an excellent guideline that will stand the test of time and be the future for further recommendations and developments in the years to come. So these are the outcomes that we have at the moment. We have, of course, the guideline, the review report, patient guideline. Those are already available on the ESHRE website, and you can read them and download them. And there is a publication that will be in Human Reproduction Open in the weeks or perhaps months to come. That's already underway and in the publication process. So that is providing a summary of what we've been talking about today. So thank you for signing on today, and we look forward to some discussion in the next session. So thank you very much.
Thank you very much, Richard, for your presentation. I will be the moderator, and I will read the questions from the audience that you can write in the chat function of the webinar. So far, we have received a few questions. The first one is, how many times a female should undergo oocyte cryopreservation, ideally?
So there's no black and white answer to that. Many women will only have time available for one opportunity for that, but where time is available, then there it may be sensible to have more than one. And we know that the success rates are dependent on the number of oocytes or embryos that you are able to cryopreserve, and therefore where there is time available, it may be sensible to have more than one round of ovarian stimulation.
Thank you. Do you think that there is any age limits for fertility preservation?
I think there are age limits, but I think it's very difficult to say quite what they are at the moment. The only age limit that we really highlighted that I mentioned today was highlighting that for ovarian tissue cryopreservation, there's evidence of limited benefits in women who are in their late 30s. That, of course, may change, and there may well be the occasional pregnancy thereafter, but the balance here is between the significance of the intervention and whether it's the optimum treatment for patients. I think essentially for ovarian stimulation and oocyte cryopreservation, embryo cryopreservation, essentially it's going to be very similar to success rates from IVF, where they do become really quite limited once women are into their 40s. That doesn't mean that it's necessarily futile, but it is an important consideration for patients as to whether they decide to do it. And of course, for health systems as to whether they want to support that for their patients or whether it would be only available on a self-funded basis.
Thank you. And the next question, is there any role of anastrozole in fertility preservation?
So I'm not aware of much literature on anastrozole specifically. Most of the literature is on letrozole as a more widely used aromatase inhibitor. And I mentioned in my talk a couple of indications for it in women with breast cancer and in transgender men. Yeah, I'm not sufficiently familiar with anastrozole as to whether it might have benefits. My understanding is that it's actually largely been superseded by letrozole, but I may well be wrong on that, and I'd be happy to have someone correct me.
I don't think you're going to have someone correcting you right now.
Right. Okay, Kenny, thank you.
Your answer is right. It's much less written about anastrozole, but it's an alternative. It could be used.
Yeah, if there was a reason why letrozole wasn't available, it would be an alternative.
The next question is about triggering. Is there any recommendation regarding the trigger? In the question says, agonist trigger should be considered in situations when the LH surge can be too weak.
Yeah, so we do discuss that. That's mostly covered in the ovarian stimulation guideline, but I think the importance for the fertility preservation situation is potentially where patients might have had long-term ovarian suppression. They may have been on the contraceptive pill for long periods of time, for example, and only stopped that just recently when their cancer was diagnosed. Or it may be a patient with, for example, endometriosis, who's had a long-term treatment with gonadotropin agonists for that. And in those situations, you may still want to use a GnRH agonist trigger where there is perhaps a risk of hyperstimulation with HCG, but I think it's one of the recommendations is that careful monitoring of that to ensure that there is an adequate LH surge is very important in these patients, as of course their opportunity to come back for a second cycle is often going to be very limited.
Thank you. The next question is about oocyte cryopreservation. Can you tell us a specific age that we can tell the patient she is not suitable for oocyte cryopreservation?
No, I can't give you that age. You're going to have to decide that yourself on the basis of your own practice, I'm afraid. I think it's a matter of discussing with patients, frankly, what the success rates are, and then arriving jointly at a decision as to whether it's appropriate or not to proceed. And of course, that is, as I said earlier, going to be around the success rates of conventional IVF, bearing in mind that these success rates do become very limited in one's early 40s.
And what about the age limit for ovarian tissue cryopreservation?
So the similar principles apply. We did have a specific comment on that, as I mentioned in my talk, based on evidence that there is, as with all degrees, anything to do with female fertility, there is a very important age effect. At the moment, we recommend that it's going to be, there's evidence that it's less likely to be successful in one's late 30s, but that doesn't mean that it's necessarily futile. But it is very important that patients are aware of the limited value of these interventions through age.
Thank you. The next question is about patients with breast cancer. What protection should be additionally used in breast cancer patients during stimulation? Tamoxifen or letrozole or both?
Yeah, so that's something that we discuss quite a lot. There is a certain amount of evidence for that. There's actually not very much evidence on tamoxifen, although there is some, and the more recent and more robust evidence really applies to the use of letrozole in that, and that is encouraging. And as I mentioned in my talk, we do suggest that that's a serious consideration in these cases. There is now starting to become more evidence that it doesn't compromise fertilization and embryo development rates, which is something that was missing in the early literature. But I think now we can be more confident that these are effective and safe things to do. I think what we're less clear about is really whether there is a long-term benefit in terms of any chance of breast cancer recurrence from the use of these drugs just using ovarian stimulation. And it may be that we're largely treating anxiety rather than real medical risk here.
What is your opinion about the low reutilization of cryopreserved material after the cancer cure?
Yeah, excellent question. This is certainly a consideration for anyone who's running a storage facility as to whether their tanks are filling up with tissue, eggs, embryos that no one is ever going to want to use. And unfortunately, this is to some extent an inevitability from this process, as we're unable to identify with robust accuracy exactly those patients who are going to need it. And of course, those therefore who could be reassured and therefore not go through this process. And of course, that isn't going to change anytime soon, because so much of this in younger patients will depend on what happens in their lives thereafter. But I think there is a clear need to consider carefully what the real risk the patient is going to have of loss of fertility, and perhaps where that risk is thought to be very low to perhaps consider whether this is an appropriate significant intervention, whether that's really needed or not.
The next question is about patients with advanced diseases. Will you offer fertility preservation techniques to women with metastases?
Yeah. Again, I think it's an area where you can't have a black and white decision, and this is another area for individual discussion and frank individual discussion, because I think you need to think about the whole process here as to the patient's likelihood of being able to use these stored materials for having a baby, because that is the object of the exercise. And that may be not possible for that patient. We've been familiar for many years with the posthumous use of sperm for men who cryopreserve sperm, and that is in many countries an allowed procedure. It is in the UK and elsewhere. Of course, consent needs to be given specifically for that use at the time of storage, and that's a really important consideration. So I think that does become a more challenging area where depending on how ill your patient is and what her prospects for survival. But yeah, I don't think it necessarily precludes use of fertility preservation in those situations. Of course, the other aspect of it is that oncology treatments are developing all the time, and what may look like not an ideal situation now, in a couple of years' time, that may change. And of course, we're talking about a very long-term process here with fertility preservation.
Thank you. Now there is a question about adolescents, and the question is not any recommendation, or do you have a recommendation for oocyte pickup technique in young adolescent girls?
Yeah, that becomes a grayer area and somewhere where the guidelines sort of perhaps doesn't cover everything that you might want it to, because we decided that we were not going to cover prepubertal girls. So that's one area. We do cover adolescents specifically, although I think it'd be fair to say that perhaps that's an area where there could have been further development. And this is a challenging area, and there are a lot of people with some experience of ovarian stimulation in adolescence, others where there's really only limited experience and people are learning as they go along. So this is a challenging area where there's need. There isn't a lot of data, a lot of evidence. It's really a matter of general local expertise.
Thank you. There is a question that maybe if I interpret it correctly. The question is about the time between the oncologist make a diagnosis of cancer and the time that the patient needs to wait until that she can attempt pregnancy. And I think the question is if you should consider that time may be also damaging for fertility, as not as much as a gonadotoxic treatment, but that it can be taken into account for fertility preservation.
Yeah, I'm not sure what the question exactly is, but I think that's an important consideration. It's most obviously the case for women who are being recommended endocrine treatment for breast cancer, where some women will now be recommended to have even up to 10 years of endocrine treatments. And of course, adding 10 years to your age drastically changes your prospects for natural conception for many women who will be already in their 30s at the time of diagnosis. So that's certainly an important consideration that we do discuss in the guideline. There is ongoing research in that regarding when and what is the right time interval for that, when is it appropriate to have a break perhaps from endocrine treatment to allow either natural conception or the use of cryopreserved materials. But these certainly are important considerations to discuss, even if all the information isn't necessarily available at the time of diagnosis. We did also identify some information that conception early after treatment did carry increased obstetric risks, and therefore a delay of a period of time, I think it was over a year, reduced those risks compared to having a pregnancy too soon after completion of cancer treatments in terms of the, as I say, the obstetric risks rather than in terms of the chances for conception itself.
Next question, is there a point in giving letrozole post-stimulation in estrogen receptor positive breast cancer patients? And if yes, for how long?
During ovarian stimulation?
Post-stimulation in estrogen receptive positive breast cancer patients.
I think you would need to take advice from your oncologist as to whether they would recommend that. I mean, clearly that sort of really strays into post-treatment ovarian suppression and endocrine therapy in breast cancer patients. And I think that's really probably a bit beyond the remit of this group to make a significant pronouncement about. I think if you're meaning just immediately after ovarian stimulation till everything settles down, then yes, I think that does make some sense. If you're going to give it anyway during ovarian stimulation, then perhaps it should be continued on until the end of that cycle. Not something that I think we identified any evidence on, but it does seem like a sensible approach of using the same principles.
The next question is very exciting. How many eggs should be frozen if you want to have one live birth?
Well, Kenny, how long is a piece of string? So, okay, so this is a very serious and important question. Actually, I mustn't be flippant about it because it is important. It does predicate on a patient being able to have more than one cycle, though, of course. Some of the best data on that comes from Ana Cobo's group in Spain, where they have given us very nice tabulations of that on their experience so far. And what they identify is in the non-oncology group that if you are able to store 24 eggs and your age is less than 35, you have a very high chance of a live birth cumulatively over using those eggs. Storing about 10 eggs gives you about a 50% chance in that age group of women. And in their analysis, actually, I think the average number of eggs per patient was 9.8, so around about 10 eggs. Of course, these are age-related results, very much so. Clearly, if you're over 35, you have a substantially lower chance of a cumulative live birth for the same number of eggs. And of course, you have the double whammy of probably getting fewer eggs anyway. Now, their clearest data was actually from women storing eggs for age-related fertility loss. They also had some data on oncology patients where actually the success rates were a bit lower than in the elective egg freezing group. Not all groups have found that. There was data presented at the annual ESHRE meeting this year from the UK, from London, looking at women with breast cancer, where they actually did find good cumulative live birth rates. So I think this is another area where we need more data, but the data that is there alludes to the sort of idea of what sort of success rate you can get with those number of eggs, but they are relatively large numbers of eggs to get the high success rates, even in younger women.
Yeah, these are really important questions for the patients and also for the doctors. And the question about how many times you should stimulate a patient or how many times you should attempt oocyte freezing is coming several times from several different...
and of course, that's one of the potential benefits of novel stimulation strategies, such as the use of dual stimulation, where you can have 2 cycles back to back and potentially approximately double the number of eggs you get in still a limited time period.
Thank you. The next question is about women with Turner syndrome, and it's about what do you think is the optimal timing for fertility preservation in women with Turner syndrome that have undergone spontaneous puberty?
Yeah, so this is an area where we felt that this was still very much at a research area rather than at an established clinical practice level, because to my knowledge, and I don't think we identified any live births following fertility preservation in patients with Turner syndrome or indeed with similar conditions. So there is some literature on that. Kutler-Cocte has published an algorithm based on his view, not necessarily his evidence, but his view of the subject, because I think, as I say, this is an area where there's really very little data. And that was based on the identification of women who still had an ovarian reserve after puberty, and therefore ovarian stimulation was going to be both technically possible and acceptable to the patient, and therefore have the potential for freezing oocytes. So I don't think this is an area, again, where you can give a clear answer, but certainly it is going to be a balance between wanting to wait till the patient is of a sufficient maturity that you would want to do ovarian stimulation versus the risk that might be losing eggs as you went along.
And we have another question about also benign conditions. For example, how to approach the patient with endometriosis. Who is the patient that should be offered fertility preservation?
So we have a section on endometriosis that I didn't really cover in any great detail in my talk, largely because the evidence is not great on that, and therefore we do have some recommendations, but they're largely pretty weak. So this is really an area which is just ripe for bigger, better research studies to look into as to what is the ideal situation, what is achievable, and what will be effective for these patients, which at the moment, it's a very challenging area on which there isn't a lot of good guidance.
And now it comes a question about what do you think about progestin prime ovarian stimulation instead of GnRH antagonist protocol?
Well, I think we recommend that novel approaches for ovarian stimulation are certainly worthy of consideration. I guess the question with that type of protocol is does it provide significant advantages in the quality and number of the eggs that you will achieve compared to an antagonist stimulation protocol, as well as on top of what is clearly a benefit from it, which is cost. And I think at the moment, my understanding is that there's still a suggestion that the results are perhaps not as good, but the cost is certainly an important consideration. And it may be that under certain circumstances, that tips the balance to make that an appropriate way for that particular group of patients or in that particular environment.
Here is a question about methods, and the question is, what is the difference between vitrification and freezing? And what are the preferred indications of each, embryo, oocyte, ovarian tissue?
Yeah, so classically, slow cryopreservation using a controlled rate freezer was really very unsuccessful for eggs. Of course, it's traditionally been the way that embryos have been frozen for many years. But of course, with vitrification, flash freezing, as you might call it, where eggs or embryos are exposed to a high concentration of cryoprotectant but for a very short time, and then frozen at a very, very rapid rate in liquid nitrogen, has clearly transformed things for oocyte cryopreservation and essentially made it a very viable proposition, whereas with the slow freezing, it basically just really didn't work. So most laboratories have moved over to vitrification for eggs and embryos, and I think that's really pretty well established. There is some literature on whether vitrification may be of benefit for ovarian tissue. At the moment, our conclusion was that evidence is inconclusive. There are pros and cons, and therefore we recommended that the most established method of demonstrated efficacy was slow freezing. That's where pretty well all the babies that have been born from ovarian tissue replacement have been through slow freezing of that ovarian tissue, and therefore we recommend that for the time being, that's the method that should be used. Vitrification, still a research area, and it may take over in future, but not just at the moment.
The next question is about drugs that we know very little about. For example, biologic drugs, immune therapy for patients with cancer, modern therapies. Is there a support platform to update data on medication and fertility risk associated?
I'm not aware of any sort of official database one can go to look at these things, but you know, it's absolutely correct that these novel targeted therapies in oncology really are not of known impact on the reproductive system in either males or females. This highlights that reproductive toxicity is not tested in many oncology trials, unlike, for example, lung toxicity or kidney toxicity. Those are very standard outcomes of clinical oncology trials, and I think we would argue the reproductive toxicity should be absolutely on their list as a core toxicity to be assessed as a routine. But yeah, we really don't know what the impact of these novel therapies is.
Is it preferable to do a whole ovarian cryopreservation or part of it? Is there a recommended minimum size also of ovarian that needs to be biopsied for fertility preservation?
So I think you're perhaps covering two things in that. Are you asking about cryopreservation of the whole ovary? Is that part of the question, Kenny, or is it really just how much tissue should you take? Let's stick to the
I think the question is, what is the amount of tissue you should take?
Yeah. So that is a debatable area. Many centres will routinely undertake a unilateral oophorectomy. Other centres will more routinely undertake ovarian cortical biopsies, where you will take the cortex of perhaps most of one ovary and leave the other ovary behind. And I think at the moment there are clearly no randomized controlled trials that compare one versus the other, nor are there robust studies comparing outcomes, even in an uncontrolled setting, that really identify that one or other is the better situation. And that may depend, the decision as to which you do will depend on all sorts of factors. Some are sort of perhaps more philosophical and some are more practical. So it depends on what you have available. It depends on the treatment that's going to be given. And to my mind, if a woman is going to have treatment that's going to have certain amount of uncertainty as to its impact, then our first plan should be to do no harm. But if someone is going to get, for example, total body irradiation, and you know there's a very, very high risk of ovarian failure and POI, then that is going to change the equation here, and you're going to be taking more tissue than you might under other circumstances. So there is debate, there's discussion. Many centres, as I say, do a unilateral oophorectomy as a routine. Of course, many women will go on to maintain their fertility even after that, but of course their reproductive lifespan may be impacted, because we know that unilateral oophorectomy in the context of then plus cancer treatment does give you a higher risk of premature ovarian insufficiency.
Thank you. Do you know if there is any evidence about quality of ovarian tissue retrieved during pregnancy?
I am not aware of any data on that at all, other than the fact that actually here in Edinburgh we have a substantial research program based on looking at a very normal ovarian tissue, and actually our standard source for that is biopsies taken at cesarean section, i.e. during pregnancy. And I'm not aware of any concerns over the quality of that tissue, and indeed it looks absolutely excellent. So I don't think pregnancy itself has any deleterious effect. It is, of course, a time of long-term gonadotrophin suppression, so the follicular architecture of the ovary will be different compared to normal. It's a bit analogous to a long-term gonadotrophin suppression state, but certainly the non-growing follicle components, I'm not aware of any deleterious effect.
There is a question about risks, and the question is, in patients with endometriosis, it could be risks associated to the ovarian stimulation and oocyte cryopreservation methods. Maybe we could extrapolate to other patients, which are the risks that can be that wish to be avoided if we are going to offer fertility preservation by ovarian stimulation. And
I mean, I think in endometriosis, and particularly with patients with endometriomas, it's been recognized for decades that those patients are more at risk of pelvic infection and abscess formation related to the oocyte recovery. And that is clearly an important consideration where that ovary is already compromised by the disease process. So that would be perhaps the major consideration. But as I say, it's been something that's been recognized in live, fresh IVF effectively for a very long time. Doing it for fertility preservation clearly will carry the same risk. I think in endometriosis, one of the questions to consider is really, why is fertility preservation going to be necessary in this patient, and what is her risk of damage to her ovary from her subsequent treatments? Clearly there's a need for more research as to what are the best surgeries to preserve fertility, because clearly that is the optimal way forward to actually be able to remove the disease without removing the natural fertility for these patients.
Thank you. And why is ovarian tissue cryopreservation not longer experimental?
It is no longer experimental. We clearly say it is not experimental. We say it has moved on to the next stage. It is innovative, is the phrase that we used, and that's based on analysis of the safety and efficacy and long-term outcomes of the procedure. We felt that it didn't meet the criteria for a fully established practice, though, as yet, and that may well change. But that is also large. We were specifically alluding to adult women, and particularly women with diseases that are, the treatment is going to, where the treatment is going to affect their fertility. And we did highlight that for conditions such as Turner syndrome, we felt that ovarian tissue cryopreservation still does remain experimental.
There is a question about the GnRH agonist during chemotherapy. It's that only indicated in patients with breast cancer?
Is that a question? Yes.
Yes.
That is where the data. It is the literature is almost entirely on women with breast cancer, and what the several substantial RCTs have shown in those conditions is that at 2 years after diagnosis or treatment, variably, women who've had a GnRH agonist during their chemotherapy have a reduced risk of premature ovarian insufficiency. And that seems to be consistent across the trials. The limitations of that is that that is invariably in those studies a 2-year follow-up period, it is not longer, and there is very, very little data on a subsequent reproductive lifespan, and particularly on subsequent pregnancies. And you may say, well, it's obvious if women don't have POI, they're more likely to be able to achieve a pregnancy. But if you that is not established. That has not been shown that having GnRH agonist treatments during breast cancer makes it more likely that you will have a pregnancy thereafter. But nevertheless, the RCTs are very clear that there is a reduced risk of POI. Now, the studies that have been done in other conditions, such as Hodgkin's lymphoma, have not confirmed that. And that may be for a variety of reasons, including that the treatments for Hodgkin's lymphoma and other situations, they are different. They have a different risk. They're different drugs. They're different regimens. And they're also patients who are generally younger when treated for lymphoma than for breast cancer. And that may have an impact as well. So it may be that in breast cancer, the combination of particularly the risk from the type of drugs that are used, there is a sweet spot where GnRH agonists and potentially the suppression that they might be working through is able to have an effect. Whereas in patients treated for lymphoma, some regimens are of relatively limited toxicity, so there's not likely to be a benefit, and other therapies are of extremely high toxicity, and therefore it's very difficult to protect against them using this type of approach. So it may be that it's the nature of the treatment rather than particularly the diagnosis that is the reason for limited ability to extrapolate from breast cancer to other conditions. So we had a lot of debate about this. It was also raised by a number of in the peer review area as to whether we should extrapolate from this. I think we need to be extremely careful about advising women on the benefits of this approach to fertility preservation when there is not evidence for preservation of fertility. Reduction in risk of POI is not the same, and extrapolation to other conditions with other treatments, I think is also unsafe. And we strongly recommended that GnRH agonist treatment is not used as a substitute for other fertility preservation methods based on cryopreservation at the moment. We didn't say you shouldn't use it in other diagnoses, such as lymphoma, but we say you should only do so after full discussion with patients of the limited evidence of any benefits.
Thank you. There is a question about patients with PCO. Should they be stimulated in a specific way? Is there any risks or concerns regarding the ovarian stimulation?
So I don't think we came up with any specific evidence regarding women with PCO and cancer or other conditions. But again, one needs to extrapolate from the Ovarian Stimulation Guideline. And I think that just chimes in with the potential benefits of GnRH antagonist protocols in that patient group, whether or not they have cancer, as would be one's normal practice in ovarian stimulation, to particularly minimize the risk of hyperstimulation in that situation. And of course, we also highlight the benefits of pre-treatment assessment using either AMH or antral follicle count, depending on which your clinic routinely uses, to judge what would be perhaps the best treatment for that particular patient. So I think in this situation, again, the antagonists are likely to have some benefits.
And now we have the last question, and it is there any age limit for the social indication?
I think again, we don't specify clear age limits for any of these things. It's a matter of discussion with the patient as to what's relevant and what's pertinent to her in her specific situation. So throughout, we have a theme here of needing to give patients accurate center-specific information as to the benefits and the risks, and that is clearly very important, where age is the key challenge under these circumstances.
Thank you very much. That was the last question. Thank you very much for all your input.
Perfect timing at 2 minutes past 2 or 3 in the Europe.
Yes. So
Thank you very much. Moderator.
Okay, thank you very much. I think we can close the webinar now.
Thank you for everyone for your excellent questions.
Thank you.
Okay, great. Thank you. Bye.
Bye-bye.
Bye.